Okay, good morning everybody. Welcome back after coffee. My name's Rebecca Bowen. I'm a medical oncologist from Bath and I'm co-chairing today.
I'm Michael John Devlin. I'm a medical oncology consultant at Barts Hospital. We've got 5 great presentations lined up for you, so if you can all come in, take a seat, close the doors behind you, we're going to get started.
So we're going to start this morning with Professor Michelle Lockley, who's a professor of medical oncology and an honorary consultant at Barts and UCL. Thank you, Michelle.
Okay, I've been told just to start, even though everyone's not quite sitting down. So here we go. Okay, thank you for the invitation. I'm going to start off today talking about some of our recent work in which we've been trying to therapeutically target the evolution of drug resistance in high-grade ovarian cancer. So for many of you in this audience who treat this disease, this kind of a disease trajectory will be really familiar to you. This is one of my patients. As you know, we treat our patients repeatedly with chemotherapy, very often containing platinum. And I think what a graph like this tells me, we all know that each time we give platinum, it works a bit less well. And I think a graph like this really illustrates the progressive evolution of resistance that happens in our patients. And I think that us, with our predominantly platinum-based therapies, have a major part in this. And of course, what happens at the end of our patient's life, just like this woman, is that they're left with chemotherapy-resistant, effectively untreatable cancer, which ends their life. And the other thing I think that most of you are very aware of is that new drug development is extremely difficult, it's costly, and it's slow. And if we think of new therapies that work and that we use regularly in our chemo-sensitive ovarian cancers, we've only got a handful of drugs that we've been able to develop and use in this disease in recent decades. Is that slide? Oh, there we go. I have to press quite hard. It's like University Challenge. Okay, and so the other thing that we've learned is that more isn't necessarily more, so increasing the dose of chemotherapy, using more complex chemotherapy combinations, treating relapse disease earlier does not help. And of course, immunotherapy has not been as yet successful in treating this disease. So in trying to address this problem, I was quite attracted to some work that was just emerging around the world, predominantly from computational biologists, who were really trying to apply some very fundamental biological principles around evolution to different biological systems. And we use it for human problems, most notably in pest control. And they were trying to see if we could apply similar principles to management of cancer. And so there are 2 concepts that I think are particularly pertinent to this that I've highlighted here. And the first one is this idea that resistant phenotypes experience some cost that reduces their ability to produce offspring within a competitive ecological environment. And that competition is really key. So when we apply that to cancer, that could mean that resistant cancer cells are less well equipped to compete for resources and so less fit compared to their sensitive cells. And the second concept that's important is this idea of competitive release. That means if you have competing species in a system, you remove one of the competitors, then the remaining species can grow better. And this is actually quite a disruptive idea when we think about it in cancer, which is that resistance could be inevitable with maximum tolerated dose chemotherapy, which is quite a controversial idea. And so predominantly in silico, people were using these concepts to work out different dosing regimens that could help to constrain the evolution of resistance. And one of the concepts is known as adaptive therapy. So I've tried to illustrate it here in this schematic, and you'll see that the sensitive cells are illustrated, of course, in teal, and the resistant cells in the peach colour. And on the top line, what we're seeing is that if we have a tumour which has some level of pre-existing cancer resistance, which I think is highly plausible given that these women present with bellies and a pelvis full of cancer. If you have any level of pre-existence, then removing the sensitive competitions with maximum tolerated dose chemotherapy removes the competition, and the resistant cells by default become the most fit. And I think this is reminiscent of what we saw in that plot of the patient at the beginning. So adaptive therapy aims to omit doses or modulate doses in order to always maintain some sensitive population that can outcompete the resistant one. And this is important to note is a treatment that aims to control rather than to cure. And so we were fortunate to recruit Helen, who's now a consultant medical oncologist specialising in gynae cancer, during her PhD, and all of the next slides describe her work. Okay, so we were already interested in chemoresistance in the lab, and we'd already made quite a large panel of chemotherapy-resistant cell lines, either by treating them repeatedly in vitro or by evolving them inside mice. We generally label our sensitive cells green and our resistant cells red, and I'll use that convention throughout the talk. So we've made a big panel of cell lines. You might see some of these names pop up during the course that are, during the talk, that are either resistant to cisplatin or to carboplatin. We've worked with them a lot and we understand them really well. So when Helen first started, she started out by co-culturing sensitive and resistant cells just in vitro, on plastic, in the lab. And here you can see that she's cultured different starting ratios of sensitive and resistant cells. And what we saw was the opposite of the hypothesis, that in fact the resistant cells always outgrew the sensitive cells. And we reminded ourselves that the important point is resource constraints. So when resources are constrained, as you might expect in a tumour microenvironment, that's when we should see competition. And indeed, when we did that in vitro, in this case by reducing serum in the available medium, we did start to see competition. So here what you're seeing is 3 different starting ratios of sensitive and resistant cells. The dotted lines are the predicted growth rate. That's based on how they grow as monocultures. And the solid lines are their actual growth rate. And you can see for this cell pair, at all starting ratios, the growth of the sensitive cells is not impacted by the co-culture, but the growth of the resistant cells slows down every time because they proliferate less. And when we extended that to the wider panel of cell lines, we saw the same thing. And in addition to this reduced proliferation, we also saw that resistant cells undergo apoptosis more than sensitive cells, particularly when you increase the amount of sensitive cells in the culture. And we moved to testing the same thing in mice, and this is one of the models that we use. So these are subcutaneous tumour nodules, and we've injected the mice with a 50-50 ratio of sensitive and resistant cells. Here on the graphs at the top, the solid line shows you the injected ratio, and then we harvest the mice over time. And you can see at both time points, 4 and 12 weeks, the sensitive cells always outgrow the resistant ones. And if you look at the histology images at the bottom, I should point out that the sensitive cells here are express GFP, whereas the resistant cells have no reporter. And so just to note, and these are things we're kind of currently investigating, I'm showing you slightly the exception here rather than the rule. Sorry, I've sort of lost my pointer. But on the slide on the right, you can see this nodule of resistant cells is actually right at the tumour capsule, and that was rare. We hardly ever saw resistant cells growing at the capsule or close to areas of necrosis, which fits with the concept that they have a higher resource requirement. And the other thing we're interested in is why do they grow as these little sort of localized islands? And that's something we're actively investigating in the lab at the moment. So we went on to actually testing adaptive therapy in our mouse models. And here we've compared a standard therapy regimen for a mouse compared to an adaptive therapy regimen. And in the table, that's our adaptive therapy regimen. So we measure the mouse tumours with calipers. If they don't change in volume, we continue at the same dose. If they increase in volume by only 20%, then we make a big increase to the chemotherapy dose. Whereas if they decrease in volume by 20%, we make a big decrease. And you can see on the graphs, we've created tumours either with sensitive cells in green, resistant cells in red, or a mixture of sensitive resistant in blue. And you can see with standard therapy, the grey indicates the administration of the treatment, that the treatment does slow the growth, but eventually they become resistant and grow back and die. And as you would expect, the treatment works better in the sensitive than the resistant cells. And when we use adaptive therapy, we can see that the tumours grow and shrink, and we would have been increasing and decreasing the dose over that time. But we're able to achieve durable tumour control here for sort of 5 to 6 months, which is a long time for a mouse to live with cancer. So this looks like the schematic at the beginning, so we're pretty pleased with this result. And the other thing we observed was occasionally a tumour would escape control with adaptive therapy, like this one indicated here. And in this experiment, the resistant cells expressed firefly luciferase, and when we excised those tumours, we found that they were dominated by resistant cells. So resistant outgrowth determines escape from control by adaptive therapy. So I've sort of shown you this already, that our mice treated with adaptive therapy live longer. And the other observation we made, which you may have worked out from the table, is that adaptive therapy treated mice ended up having more drug overall than standard treatment, and standard treatment is indicated by the dotted line here. But when we sort of control that for the extra survival of those mice and look at the carboplatin dose per day, it's no different. And encouragingly, it was very well tolerated by the mice. We didn't see toxicity, and it's quite common to measure animal weights as a measure of toxicity, and it wasn't impacted by those higher drug doses. So at this point, everything I've shown you before, all the models can be criticised. They're not people, and we made, I think, quite a bold decision to go on and design a clinical trial. It's called ACTOV. Some of you are recruiting to it stands for Adaptive Chemotherapy for Ovarian Cancer. So when we set out to design this trial, we knew we were going to look at RISAP disease because this is very experimental. We knew our patients needed to have some degree of platinum sensitivity, and we wanted to stick with just carbo. So there had to be patients in whom it was reasonable not to give combination chemotherapy. And so we think most of our patients are actually going to have quite resistant disease. They're going to be towards the end of their lives, although we do expect to capture a small number of patients who are not fit for combination chemotherapy and having treatment in first relapse. We're fortunate that we could use CA125 as a proxy for tumour burden. And because we really want to understand if this is working, how it's working, we have a huge number of translational endpoints. So the next difficult decision was, what should the adaptive therapy regimen be? Because of course, there is no end to the number of possibilities. And to cut to the chase, this is the one we settled on. So compared to the mice, we're asking for a bigger change in CA125 before we make a dose adjustment. And we're only adjusting by 1 AUC at a time, so 20% dose adjustments compared to 50% that we did in the mice. And this was based on an existing clinical data set, courtesy of Charlie Gawley, of CA125 changes in women treated with single-agent carboplatin. It was based on our PPI groups and also the ovarian cancer subgroup, so you guys, and our funders. And so this is the final regimen. It is honestly less adaptive than we would like, but we felt that we didn't want to underdose with adaptive therapy. So it's the first of its kind trial. It's a proof of concept thing, and we didn't want to underdose anyone. So to be eligible, have to have high-grade serous or similar ovarian cancer. They essentially have to have some degree of platinum sensitivity, but any number of prior lines are allowed. Of course, they have to be CA125 secretors, but we're allowing up to ECOG2 because it's single-agent carboplatin. But what it does mean is this trial population is likely to be more elderly, more heavily pre-treated, and potentially less fit than your average trial. We are powered to detect progression-free survival. We've got a load of secondary endpoints, importantly including cumulative carboplatin dose, but also things like deliverability and acceptability, because this is highly experimental. This is the trial schema. I've told you all of this already, I think, but just to point out, standard therapy goes on for 6 cycles, whereas adaptive therapy can potentially go on for longer. We're open in 10 sites around the country, indicated on the map here, so thanks to all of you guys for recruiting patients. And it's completely charity funded, because of course, who else is going to fund a trial like this? And the protocol paper is out if you want to read some more. Okay, so I mentioned that we are collecting a huge number of translational samples. Biopsies we've kept as optional, just to promote recruitment, or not to create a bar to recruitment, I should say. So if you are recruiting to the trial and have capacity to carry out biopsies at your site, please do so. We're really interested in the biopsies. And we're collecting a huge amount of DNA, of blood in strep tubes, so we can extract cell-free DNA. So we've costed for over 1,000 tubes in total from just 80 patients. And we want to use this to answer questions like, can we quantify drug resistance? How is that evolution of drug resistance influenced by a treatment regimen? And how, of course, does that relate to survival? And there's one idea that we've developed. So this is a bioinformatics pipeline that we published a few years ago now. And it's based on our observation that as patients progress sequentially through lines of treatment, they start to acquire new copy number variations in their circulating tumor DNA. And what we were able to use is quantify, use these as a sort of a marker of the evolution of resistance. We don't think they're drivers, and they're highly patient-specific, but we can measure them over time and use those as sort of to quantify the emergent resistant population. And in a small number of patient samples, it should say delta CA125, sorry, on the y-axis, but they do correlate with a change in CA125, so certainly relate to tumour burden. And this is something that we would really like to significantly extend with the ACTOV patient sample set. So this is our recruitment graph. We've got one more site left to open. You can see that we're plodding along. We're kind of tracking, I think, along the projected curve. So thank you to all of you who are recruiting your patients around the country. It's not the easiest to recruit to, so we really appreciate your effort. If you're a site that doesn't have ACTOV and you're interested, please do let me know, because we are interested in bringing additional sites on. And just to finish with thank you. So Helen did most of this work. Trevor Graham is a long-term collaborator and sort of partner in crime in all of this. And I've highlighted Winnie and Esther, who helped me with the maths and bioinformatics that you've seen today. And of course, UCL CTC. Questions at the end.
Fantastic. Thank you very much, Michelle.
Yeah, so next we're going to welcome to the stage Beatrice Malacrida, who's postdoctoral researcher at Queen Mary University in London, who is presenting on lessons from reconstructing the tumour microenvironment of ovarian cancer and the implications for targeted therapy.
Thank you. So, yes, my name is Beatrice Malacrida, and I'm a postdoc fellow in Fran Bolquist lab. Today I'd like to talk to you about a bit of what we are doing in Fran's lab for now about 10 years. So starting off like 10 years ago, Fran and her team felt the need to really understand the biological implication underlying in the immunosuppressive status of the tumor microenvironment of high-grade serous ovarian cancer. And also there was a need for more relevant and reflecting model of the tumor microenvironment, both in vivo and in vitro. So her team decided to embark in a very complex study, use 20 to 30 patients on mental metastasis, from which they did a deep proteomics and loads of omics results, and also architectural study to try to really understand and underpin the mechanism underlying an immunosuppressive. So we use these data now as validation and template to reconstruct the tumor microenvironment for high-grade serous ovarian cancer in the lab. We do so with have improved our mouse models, and we introduce new mouse models, but also we introduce in silico data with RNA-seq or single-cell RNA-seq. But the main focus of my talk today will be the multicellular model, which are in vitro model that we do in the lab, together with some vascularized chip and some live imaging. So the project that I'm currently working on is working on this pentaculture model. It's called pentaculture because it's a 5-cell type system. And we use for this system primary cells isolated from macroscopically uninvolved momentum from patient undergoing gynecological surgery at the Royal London Hospital in collaboration with Professor Ranjit Manchanda and the BART's gynecological surgeon team. So we isolated sequentially primary adipocytes, fibroblasts, and mesothelial cells, which we then combined together with malignant cells that we have in the lab, high-grade serous malignant cells, and monocytes that we isolated from blood. The pentaculture look really small, as you can see here in comparison with a 20-pence coin, but they are really mimicking the tumor microenvironment of high-grade serous ovarian cancer, or at least we think they do. As I said, in the lab we have 3 different malignant cells that we highly characterize them, high-grade serous malignant cells. The AOX1 comes from the Australian ovarian cancer study, gifted by Professor David Botel. We also isolated from one of our own patient, G164, which comes from the Royal London Hospital, and also we have the OVCAR3, which are commercially available. And as soon as I added these malignant cells to the culture, to the complex model, I can appreciate straight away how those models were macroscopically looking differently depending on which malignant cells I was using at the moment in the culture. Also, I could actually see how those they were quite mimicking human mental metastasis, as you can see in the panel below. But as my first observation was that the malignant cells were kind of driving and imprinting the microenvironment in my models, I embarked in doing a bulk RNA-seq experiment to try to understand if this was the case. So in this bulk RNA-seq experiment, we designed that to have an end-of-free replicate. We isolated the primary cells, adipocytes, mesothelium, and fibroblasts, from 3 different donors, and we kept those donors constant when reconstructing the microenvironment. We used one monocyte single donor throughout all the study, and also so that the only difference between those pentaculture was going to be the malignant cell we were using off. Those data were then analyzed by our bioinformatician Eleni Magnati and by Samara Lorbani. What we first saw is that the cell line that we also sequenced in 2D level were clustering separately from anything that was related to tissue. So the fibroblast themselves, the mesothelial cells, and also from the original tissue from which we isolated the normal cells from. But also what was more interesting for us was that the malignant cells, the pentaculture, were clustering together according to the malignant cell that we use and not according to the donor that was originally used. Kind of like suggesting that the idea that the malignant cell were kind of imprinting the microenvironment as seen before from the morphological H&E was actually correct. So we went on and took this analysis a step further. At the time, Dr. Samara Lorbani in the lab was a PhD, clinical fellow PhD in the lab. Now she's a clinical lecturer at the Barts. And she had collected results, single-cell RNA-seq results on actual human-mental metastasis from patients. And what she did is that she used the clusters of macropopulation that she identified in our single cells from patients to deconvolute my bulk RNA-seq data. So in this graph here, you can see the macropopulation expression of those clusters, cancer cells, fibroblasts, mesothelial cells, and macrophage present in my pentaculture. But then Samar took this a step further and looked in particular at the macrophage subset and cluster, which are normally present in omental metastasis from patient. And what she found is that the same cluster that were actually in the patient were also present in my tiny, small pentaculture. But what was more important is that the proportion of those clusters, as you can see here from the light green group or the purple or blue group, were actually different in abundance depending on which malignant cells I was using. We then validated those results. I'm going to just show you here 2 examples, as we know that RNA does not always translate in protein. So we validate at protein level using both flow cytometry or the released cytokines. And you can see here the GPNB macrophage, they are both graph, is showing differences in the expression and the relative proportion in the RNA is the light green clusters. And similar results we obtained with CCL4. So we were wondering then what was the difference between those 3 malignant cell lines. We know there were high-grade series, but we want to know a bit more. So we went to do genomic analysis and transcriptomic analysis of those malignant cells, and we saw that they were all the 3 cell lines were carrying P53 mutation and a plethora of different genes, gene alteration and copy number variation that are always normal in high-grade serous ovarian cancer. So we didn't have a BRCA1 or BRCA2 deficient cell line, but we look at the transcriptomic of those cells, and we saw that the homologous recombination program was transcriptome was actually downregulated in one of which is the G164. So as I said, like all of those mutations and copy number variation are very common in high-grade serous ovarian cancer. So we are really trying to see if we can find in these results still now something that is really maybe overlooked or not looked at often to try to find the difference among those cell lines. But as we want to use this platform, this pentaculture, to investigate more the biological mechanism underlying the immunosuppressive status of the tumor microenvironment of high-grade serous, I bring this graph back to you to show you the macropopulation again, and I pointed out here the cancer cell population, which are in fact at the end of the culture seems to be at the single-cell RNA level, seems to be higher in G164 compared to OFCA3 and AOX. So we look at the presence of cancer cells on the end of the culture in the model, and we actually see that the RNA level were matching again the protein level, meaning that the G164 cancer cell were surviving or be proliferating more on the pentaculture compared to AOX and OFCA3. So when wondering why this was the case, I looked back at the transcriptomic data and I realized that some of the phagocytosis pathway were upregulated in AOX and OFCAR-free pentaculture compared to the G164. So I then used lentiviral, which are red label cells, to go and check how many macrophages were positive for the malignant cells. And I found out that the reverse of the graph before, the graph above, showing that in fact OFCAR-free and AOX show an increase in macrophage phagocytosis of the cancer cells compared to the G164. So a colleague of mine, Dr. Florian Laforette in the lab, has developed a tissue slice technique which allows him to image, to video record a time-lapse video of ex vivo tissue from patients and see the movement of macrophage and T cells. So I've asked him if I could I could use this technique to do the exact same thing with my pentaculture here, and him in collaboration with Dr. Faisal Karim have analyzed those videos for me. So this is an AOX pentaculture. I'd like you to look at the green cells, which are the macrophage, and the red cells, which are the cancer cells. And you can really see that in the AOX pentaculture, there is a couple of macrophages which are really interacting with the malignant cells. While in the G164 pentaculture, the culture which has the least phagocytosis, you can see the macrophage moving around together with the stroma, which is in blue and purple. They seem to try to engage with the malignant cells, but they are not really doing it. Again, when we look at the OFCAR-free pentaculture, which has the highest level of phagocytosis, we could really see that there are loads of macrophage strictly contact with cancer cells. It's just in that really those macrophages are trying to engulf the cancer cells. So as we wanted to take this platform a step further and see if we can use and try and test some targeted therapy, we're trying to aim to target phagocytosis in this case. And to do this, we focus on the expression of two receptors, CD47 and CD24, which generally are expressed by the cancer cells. And when coupled with SERP-alpha and Siglet-10, respectively, on the macrophage, this triggers the do not eat me signal process, so the phagocytosis is getting inhibited. We checked that the level in the OFCAR-free, in this case, both 2D and pentaculture of both the receptors and on the cancer cells and the macrophage was present, so that then we can try to treat those pentaculture using either an anti-CD47 antibody or an anti-CD24 antibody to restore phagocytosis. So we did, and in fact, when we treat the OFCAR-free pentacultures with an anti-CD47, we obtain a significant decrease in cancer cells number and viable, and a subsequent increase of phagocytosis. And the similar results we obtain with an anti-24 antibody. So I went to look back to the movies of those and videos of those pentacultures, and this again is an OFCAR-free pentaculture control. Again, the macrophages are interacting because, as I told you before, they have a high level of phagocytosis with the cancer cells. But when I treat that with an anti-CD47 inhibitor, you can see way more macrophage interacting with the cancer cells, suggesting that the phagocytosis is in fact restored. So just to conclude from this project, we developed a 5-cell type model of high-grade serous ovarian cancer that tried to mimic the omental metastasis of patients. Also, we found macrophage subset at a single-cell level that were present in the human patient, were also found in the model, in our model, with proportion dependent on malignant cells that we use. Also, we identified some phagocytosis pathway, and we have found a way to treat them on the pentacultures. And so we think that we can use this model to potentially test macrophage-targeted therapies. So another project that we have in the lab is led by a PhD and now postdoc, Dr. Joash Joy, which is very interesting in CAR T-cell activity. We know that CAR T-cell, they don't really work in solid tumor. So during this project is trying to design a microfluidic chip that try to mimic the vasculature of the body. And in the central wall of this microfluidic chip, it added less complex model of primary fibroblast malignant cells encapsulated in collagens to mimic, the mental metastasis, and try to deliver CAR T-cell through the vasculature. So first step was trying to make the vasculature. So he added the cells, which then made the vasculature, as you can see from the red staining in the CD31. And you can see the left-hand side, where you see the more green staining, is the actual core of the gels, while the part on the right is just outside. So the vasculature was well formed. So when he realized that, he started to deliver the CAR T cell through the side channel of the microfluidic chip to see if those CAR T cells were able to reach inside the collagen gel. So you can see here from the movie one of the green CAR T cells that is floating around the vasculature. And in his paper, which was published last year in Cancer Research, he found that, again, malignant cells' intrinsic factor can cause resistance to CAR T cells in an antigen-dependent manner, and he found a way to counteract that. Also, we found that the sensitivity to CAR T cell can be modulated by fibroblasts in both positive or negative way. Last but not least, this is a project that is being developed now in the lab by our PhD student, Rachel Bryan Ravenscroft, which is in collaboration with Professor Ranjit Manchanda. Rachel took this a step further and took the ability of our lab to make a 3D model, actually a step behind, because she's trying to understand early-stage high-grade serous. So she's using this hanging drop model in which she incorporated fallopian tube cells, both wild type or P53 mutated, together with fibroblasts and monocytes. So this is very, very preliminary results. You can see here the results from monocultures of fallopian tube cell wild type and P53 mutant and co-culture with the fibroblast. And already from the morphology, you can appreciate the differences between the wild type monoculture and co-culture, or the P53 monoculture and co-culture. Also, she developed a method in which she can analyze projections an invasive area of those spheroids by using microscopy and dyes. And again, you can see the differences between the fallopian tube wild type monoculture and co-culture, compared to the P53 mutated cells. Again, she took this a step further because we don't like to have very easy models, so we like to have multiple cells inside our models. So she used, in this case, monocytes, and she had them into form a triculture. And again, I think you can appreciate for those two images how different are the triculture made it with fallopian tube wild type cells compared to the P53 mutated. She's now trying to find ways to best analyze these and to try to understand what actually all of this means. And with this, I'd like to thank you, my supervisor, Professor Van Bolkwil, all the team at Barts that helped me with this work, in particular Samara Lorbani, Eleni Magnati, Faisal Karim, the Center for Tumor Microenvironment. I'd like to thank also the Ranjit Manchanda and the Barts surgical team for their amazing help with collecting tissues from sample, Mr. Hovenith from the Royal Marsden, and thanks for a patient donate the sample to us.
Thank you very much. We're next going to have Professor David Huntsman from the University of British Columbia, Canada, who will be presenting on new perspectives of rare gynae cancers.
So thank you so much for the invitation to be here, and I really enjoyed today and look forward to learning more with you over the next couple of days. So a couple of disclosures. I do advise a company, and everything I do is a team sport, and there's lots of people involved. Our perspectives on rare cancers have changed since the introduction of genomics and NGS. We used to have these rare kind of histologic variants of common cancers, and most of those have been shown, like tubular breast cancers, to be kind of nothings. But we do now have molecularly defined subsets of common cancers, which are indistinguishable from their counterparts, like polymutated endometrial cancers. And then in the traditional rare cancer space, we have histomolecular entities like granulosa cell tumor, and then cancers which have really unusual histogenesis, but very common mutations like chordoma, which is obviously out of spec for today's presentation. These histomolecular entities, I live in a mountainous place, and so using a ski hill analogy, if common cancers are a bit like a normal ski hill where you have a cell of origin at the top and a cancer at the bottom, and many different ways to get from A to B, the histomolecular entities are more like a luge run, where you've got one way to get from A to B. And so if you can find out what that way is, it can become a biomarker, and perhaps a way of identifying treatments. The latter has proven way more difficult than I expected. Of course, other people might have gotten onto that earlier. So as you know, my views of these rare cancers has changed over the years, and I was filled with hubris when NGS came along, and I thought we'd define them all by distinct mutations, and that would be the answer to everything. And it obviously proved not to be the case. In particular, it's been really difficult to figure out what these mutations identified by unbiased sequencing actually mean, and in particular mutations which impact the epigenomic machinery, because of course cell context is defined and maintained by the epigenome, so the impacts of mutations which perturb the epigenome have to be considered in a very specific cell context fashion. And that's why most of the studies on things like ARID1A actually make very little sense, and we still don't know what those mutations really do in terms of leading to oncogenesis. And so cancers aren't just a sack full of mutations, of course. They represent this kind of interaction between a cell of origin, mutation, or microenvironment. It's a bit like going on a journey. So, you know, where you start from, the terrain you cross, and what happens along the way will impact what you look like and where you end up, kind of thing. And if you change any of these variables in cancer, you basically end up with a different neoplasm. And we see, and the gynae cancers are a wonderful example of that. So each of these cancers represents a manifestation of the endpoint of an oncogenic journey which includes those factors. So given that, I'm going to talk about three gynae cancers, granulosa cell tumors, where we know the cell of origin, there's a pathogenic mutation, but there's been incredibly slow progress. Small cell hypercalcemic ovarian cancers, where we don't know the cell of origin, and there's a confusing mess of biologically informed treatment options. And then a clinical scenario, coexistent, or what were called synchronous endometrial and ovarian cancers, which is sort of an organ-specific landscape effect. So granulosa cell tumors, of course, they represent the most common cancers among sex-cord stromal tumors. They can have a protracted course with multiple surgeries. We still need non-surgical treatments for relapsed cases, and we don't have good treatments. We'd found the ARID1A, the FOXL2 mutations in 95% of these cases a few years ago, and we've learned a little bit more since then, but not nearly as much as one would have hoped or expected. Obviously, juvenile granulosa cell tumors are a different disease and have more common, standard kind of cancer pathway type mutations. So we know the FOXL2 gene is mutated, specific point mutation in 95% of cases, and there are some other mutations which are rarer, which may or may not have much clinical relevance other than P53, which does seem to indicate a much more aggressive course. And we know that FOXL2 is a critical transcription factor in maintaining and maintaining the female state of gonadal stromal cells. So it makes sense it would be important in this tumor type. So, but why is FOXL2 mutation so specific for this cancer? And I just came from the sort of WHO pathology kind of meeting, and when we see FOXL2 mutated in other stromal tumors, it may be that they are granulosa cell tumors, but just look a little bit like some other entity. So we haven't quite sorted out whether to bin all the FOXL2 mutated cancers together or not. But in adults, FOXL2 expression is basically limited to Müllerian stromal cells, so uterus, fallopian tube, ovary. We don't know why we don't see FOXL2 mutated stromal tumors in those other organs, but if, for instance, in a stromal cell in your leg, a FOXL2 mutation happened, it's not expressed, so nothing can really happen downstream. So the mutation, because we don't see these cancers in the fallopian tube and uterus, it probably has something specifically due to the function of the granulosa cells themselves and how they cycle and die, and perhaps these mutations prevent that kind of loss of granulosa cells. There have been some studies on this. It's not a surprise that FOXL2 is a transcription factor. This point mutation may change transcription factor binding. There was another study which showed that the binding partners may shift a little bit, but neither one of these studies, we did the first, this is a second one which was published at the same time, have been really validated. And a much more recent study, which sort of makes sense in the context of what we know about granulosa cells, is maybe this mutation changes the glucocorticoid signaling pathways in granulosa cells, and that may be how they're oncogenic. Again, needs to be validated. So this is really disappointing. We found this pathognomonic mutation. I thought, hey, that's going to be the answer. 16 years later, we have a diagnostic. We know that a lot of the cases which used to be called granulosa cell tumors and had aggressive courses were not granulosa cell tumors, so it's helped us in defining the disease, but we have no biologically informed treatments, and we also have had no real way of dealing with some rather illogical aspects of management, like the reluctance to offer hormone replacement therapy post-BSO to patients who've had adult-type granulosa cell tumors. Why such slow progress? Well, we have a single cell line, which is absolutely tricky to work with, and there was nothing else. And there were no these tumors don't grow as xenografts. But good news is there's now, in the last couple of years, there's been 2 mouse models which can produce tumors, which can be studied. Presumably, we can use them to test new treatments, and maybe there'll be some progress. This is about rare cancers. I don't think anything gets rarer than small cell hypercalcemic ovarian cancer. I presume you have about a dozen cases per year in the UK each year. These are first described by Robert Scully in 1979. Very rare disease. It's tragic. The mean age of onset is 22. I think the youngest patient was 2 years old. They're familial in about a third of cases. And you can sometimes see elevated calcium, but it's certainly not diagnostic. And the sad thing is this is a lethal cancer, 35% 2-year survival. Our group, with 3 other groups, found that these cancers almost always have mutations in the SMARCA4 gene, which is part of a chromatin remodeling complex. And this became immediately diagnostically useful because when you look at ovarian cancers, and in particular ovarian cancers which look like small cell hypercalcemic ovarian cancers, is loss of BRG1, in particular if accompanied by lack of expression of BRAMA, which is another part of the complex, is basically defining for this cancer type. But the diagnosis has to be made really quickly because this is an incredibly aggressive disease, and any kind of delays in diagnosis and referral can be lethal. Lots of people study the complex in which this protein belongs to. It's called the switch-NIF chromatin remodeling complex, and it's one of the key regulatory mechanisms through which chromatin is opened and closed to allow gene expression. And because there was a whole scientific community interested in this complex, and this became the kind of key kind of SWE/SNF-driven cancer when it was described, there actually turned out that I think there were more people studying the cancer than there were patients. And so a lot of interesting things came out of that, but in a rather confusing way. Lots of people study the switch-NIF complex, and because it controls a broad array of different gene expression and different pathways, the mutations implicated a lot of things from cell growth, proliferation, metabolomics, and we really don't know what we should carry forward clinically. Our group did some work, and there's lots of different studies like this. We found that these tumors don't express a protein called arginine succinate synthase, which is not expressed in this cancer compared to other cancers. And this is a key protein which is required to make arginine from citrulline if you don't have adequate supply. And so these cancers in vitro models, in vivo models, patient-derived xenografts, respond massively, really well to this drug called adipeg-20, which mops up arginine and makes cells rely on making their own arginine. But we don't know how to carry that forward. And the reason why is that the literature is actually kind of stuffed full of treatment options for this cancer. And as translational researchers, I think we really have to get our act together. And my team, along with Sid Huang's team from McGill, can probably be blamed for a lot of these papers. But there's good stuff here, but what would you want to take forward in a clinical trial? And so we have to do a much better job of figuring out, which ones of these options could be perhaps put in combination. And so I think this is a space where we have to start doing mouse trials, because doing patient trials of more than one option is going to be nearly impossible. And so I know that in terms of the CDK4 inhibitors, this has, Amitosa is including this in a study, so this piece has gone forward. But while this has been going on, there's a AYI oncologist, Joseph Pressey from University of Cincinnati, who's really focused in on this cancer and have become a referral center from around the world. People contact him. And he's been using very aggressive pediatric protocols for these patients and is actually seeing survival way better than what has been described in the past. Now, his protocol did include radiation therapy, and he had 2 patients who died of complications from radiation therapy, so he's since removed that from the protocol, but those patients' events are included in these plots, which suggests that this is way better than what's been offered before. But you can't kind of wait around with this tumor. This is some other data which Joseph shared with me, where it's patients who have familial small cell hypercalcemic cancer, and this is the time in days in the column which is highlighted between the last normal scan and when the patient's presented with what was usually metastatic cancer. And so, like, every day counts here. And it shows screening's not really going to work as well. But, it is a sort of diagnostic, or if something can be described as a pathologic emergency or stat situation where you can't mess around thinking about scratching your head, if you think this is what it is, get the attention of a major referral center, or if you're the major referral center, get ready to give this patient very aggressive treatment because it could make a difference. So, where are we now with these sort of discoveries in rare cancers? And I don't want to diss other people's work, so I'll diss my own work, is that it's been incredibly disappointing in the minimal clinical impact finding pathognomonic mutations has had. And so we're trying another approach right now, and I believe there are people in the UK doing the same thing, thinking that can we identify these rare cancers rather than focusing on how they got the way they were, but what they are right now, and could there be targets such as antibody-drug conjugates or T-cell engagers, which perhaps have been developed for other cancer types. And so I saw a paper from Simon Harrington and Charles Gawley recently. They were looking at common ovarian cancers. We're developing a cyclic IF screen of about 20 targets for ADCs and T-cell engagers, and we'll run it across all of our tissue arrays and hope we can find some hits and help directing cancer types and patients to trials. And when we don't find anything, have those cancers as the targets for more discovery-based research using mass spec. But when we think of things like granulosa cell tumors, they have nothing in common with a high-grade serous cancer, so they don't express folic acid receptor alpha or TROP2 and things like this. We're probably going to find targets in common with other sarcomas, and so we have to look outside the box and in other organ systems to find treatment opportunities. So I'm going to end with a couple of words on these synchronous, or now called coexistent, ovarian cancers. So they're known to present in about 10% of endometrial cancer cases. It's long known that these have a better prognosis than what we would expect with metastatic cancers. Our group and the group from Memorial at the same time showed that there was a clonal relationship between these tumors, so they were sort of metastasis. We know that the relative levels of how close they are and the outcomes differ between cases. And there was a nice paper last year from Simon Harrington. And Ernst Lengel had a lovely paper which showed likely endometrial origins for these tumors. So the ovarian tumors are in almost all cases metastasis from the uterus. But we know this doesn't predict further metastasis because it's sort of not like moving out of your house, it's like moving into your basement. It doesn't show that you can live in the outside world. And as the ovarian cancers are likely metastasis, the term coexistent has been favored. I'm not sure whether it really matters so much, but that's the way the terminology is going. But what to do about them, that's the important thing. So FIGO introduced a stage 1A3, and which identifies patient with good outcomes, but it's very limiting, and FIGO has to be conservative, and it is conservative. So this is work led by Jessica and McAlpine and Amy Jameson from our team, and where we had 154 cases, and if we looked at the FIGO classification, only 33 of them fit within cases 1A3, and there was only one adverse event in that group. So yes, it does work, but there were lots of patients left behind who did extremely well. And so we worked to include the molecular subtypes, and so within this low-risk group, we want to add patients who are NSMP ER positive or polymutated. And by doing that, we end up with a much larger group, shown in green, who have extremely good survival. But this needs prospective testing before use. And if anyone's interested, there's a clinical trial led by Jessica and Amy called the COMPARE study. And it was designed by CCTG in Canada with some help from the UK, endorsed by GCIG, and they're really looking for other collaborators. So if anybody's interested in taking part in this, please contact them. So at this point, I'd like to thank you all for the invitation. Look forward to engaging with you in the question period at the end of this. And of course, would be love to engage with you during discussions over lunch and coffee. So thanks very much.
Thank you very much indeed. Next is Dr. Aaron Miller, consultant medical oncologist and early phase clinical trialist at UCL and Barts. Thank you, Aaron.
Hi, good afternoon, everyone. Thank you for inviting me to speak. So I'm going to take a slightly different approach and talk about more clinical aspects of applying precision treatment to non-high-grade serous ovarian cancer. I think this is really the stage where we're beginning to bridge the gap in personalised care. We all know with the widespread advent of BRCA testing, HRD testing, that particularly in the first-line setting, we're really making individualised patient decisions for maintenance therapy, but this really only applies to high-grade serous cancer. So where are we with the other cancers? These are my disclosures. And why we should focus on non-high-grade serous epithelial ovarian cancers is it represents a significant proportion of our patients, between 10 to 25%. In the past, we managed them all the same, like high-grade serous, but we know now that they have really diverse biology, they respond differently to treatment, and have different resistance patterns, disease patterns. And if we can apply more precision medicine, hopefully we have an opportunity for better outcomes, and we can reduce the toxicity versus empirical chemotherapy. We all have somewhat dread when we're starting second or third line chemo in patients with advanced mucinous and clear cell cancer, and it would be really nice to have some different options for these patients. Many of them present with early stage disease when the prognosis may be good, but we know that in advanced disease, the survival outcomes from non-high-grade serous are poor. So this is old data now from all the GOG studies, looking at the progression-free survival in the top and the overall survival for the different subtypes. And you can see that the grey line, the clear cell, and the red line, the mucinous cancers, have far worse progression-free survival and actually a noticeable deterioration in overall survival compared to high-grade serous. And it's likely that the gap is bigger now because we've seen the improvements that PARP inhibitors make in the high-grade serous cancer. And then here, this study, looks at the risk of progression or the risk of death in all subtypes versus high-grade serous. And you can see, with the exception of the endometrioid ovarian cancers, the likelihood of progression or death is far higher for all the other subtypes. And I highlight the ones in red, the mucinous and the clear cell cancers. Advanced mucinous cancer has a 2.7 hazard ratio increased risk of death versus high-grade serous, and clear cell 2.2. We've known for some time that these cancers have different sites of origin, they have different molecular profiles, and the high-grade serous has been well described. About half of them are HRD with or without a BRCA mutation, and then we have these patients that are HR proficient. But when we look at the other subtypes, particularly thinking about potential targeted therapy, we've got the low-grade serous groups, often have mutations in the MAP kinase signaling pathway, the endometriosis-associated cancer, so the spectrum from clear cell to endometrioid, frequent overlapping mutations, ARID1A, PI3 kinase, beta-catenin, and these are the patients that have mismatch repair deficiency, about 10%. And then finally, this last group, the mucinous cancers, we're still not entirely clear of the site of origin, and in terms of targeted therapy, KRAS mutations, like the high-grade serous, they have frequent P53 mutations, and perhaps some overexpression of HER2. So starting first with the low-grade serous cancers, probably about 10% of all ovarian cancers. Many of them present with early-stage disease, and because of the relatively indolent nature of them, actually the 5-year prognosis is not so bad. Surgery is the mainstay of treatment. But what we've established over the years is they have frequent mutations in this MAP kinase signaling pathway. So this cartoon diagram shows you the various types of receptors all focusing in and signaling on this KRAS, RAF, MAP signaling pathway, which drives cell growth and differentiation. Depending on the studies we look at, probably between 15 to 55% of low grades have a KRAS mutation, another 5% have a BRAF mutation, and even before the advent of targeted therapy, this was shown to be prognostic. So in the Kaplan-Meier curve on the bottom, the upper line, that's the patients that have a KRAS or a BRAF mutation. So even without taking into therapy considerations, they have a prognostic advantage. There's a lot of interest in this because there are a number of drugs that target this pathway, the MEK inhibitors, which are used in other cancers, and in fact these have been examined in low-grade ovarian cancer. The first study looking at binimetinib, which was a study run by the American group, disappointingly showed no difference between the MEK inhibitor or standard of care. So the physicians were allowed to choose either chemotherapy or hormone therapy. But actually, when they looked at the data retrospectively, those patients with the KRAS mutation did benefit from the binimetinib. And then the LOGS trial, which we ran in the UK and many other places, looked at trametinib against physician's choice, either chemotherapy or hormone therapy. And in this trial, there was an improvement. So there was about a 6-month improvement in progression-free survival. And regardless of what of the clinical subtypes or the comparative arm you looked at, a benefit was seen with trametinib. And this led to the approval of the Cancer Drugs Fund for trametinib with low-grade cancers. And again, this study wasn't powered specifically to look at those with a mutation, but if you look at the response rate, the patients with a KRAS or an NRAS or a BRAF mutation had far higher benefit than the wild-type patients, so a response of 50% versus 8% and an improvement in progression-free survival. One of the problems that we have when we target a single point in a pathway is that the cancer cells are far smarter than we are and upregulate compensatory pathways in order to become resistant. And we've seen this in many other cancer types. So single-agent targeted therapy is often not doesn't provide a long-term disease control. And this forms the basis of the RAMP study. So this was looking at giving a MEK inhibitor, a dual RAF MEK inhibitor, ofentanib, with a FAK inhibitor. So the FAK focal adhesion kinase pathway is one of these pathways that's often upregulated when you inhibit the MAP kinase pathway. And here, patients, this was a phase 2 study, with recurrent low-grade cancer, regardless of the KRAS status, were randomized to receive either the combination or the monotherapy. And the waterfall plot at the top here, every bar represents a different patient. Those going down show a response in the tumour. And you can see that actually most of the patients had some degree of tumour shrinkage. But actually when we look at the RECIST response, which requires 30%, only a 10% response rate. But when you give the two drugs together, a far deeper amount of response and an overall response rate of 45%. In both studies, the amount of disease control, so the people whose cancers did not progress, was very high. And in looking at the charts, the blue bars, they are the ones with the KRAS mutation. So it seems to be that the benefit is greater in the KRAS mutant patient population. And on the basis of this really small study, the FDA in the USA gave orphan drug approval and recently accelerated approval to the combination of this these two drugs for patients with recurrent low-grade cancer who had the KRAS mutation. Now, the European regulatory authorities will not approve drugs on this limited amount of data, but there's a confirmatory phase 3 trial running whereby patients with recurrent low-grade cancer are randomized to receive either the combination of the two inhibitors or physician's choice chemotherapy or hormone therapy. And this trial is actually very close to recruitment, so hopefully we should have the results of this soon. In the interest of time, I'm not going to talk about hormone therapy, hormone therapy for treatment for low-grade cancer, but move on to clear cell cancer. So again, this is a tumour group affecting younger patients, about 15% of patients in the UK, but we know the incidence is far higher in the Far East, up to a quarter of all epithelial ovarian cancers, and that's due to its association with endometriosis. The most common recurring mutations are in ARID1A in up to 50 to 60%, the PI3 kinase pathway in about a third of patients, and about 10% are mismatch repair deficient. We know that these patients do really badly. The response to first-line chemotherapy is about 40%. The response to second-line treatment is really single-digit. And I include this data from the NIC trial. It was a negative trial, but just to show you how bad things are. So these were patients with recurrent clear cell cancer. And in the chemotherapy, the standard of care arm, the median progression-free survival was 1.9 months, and the median overall survival less than 5 months. So really a need to come up with different therapies for these patients. The ARID1A mutation is the most common recurring mutation in clear cell. We've heard a little bit about that from David, but this is a tumour suppressive gene that functions in the chromatin remodeling complex. And this is probably an oversimplification, but the preclinical models suggest that it may sensitize to different therapies. So Essentially, when you lose ARID1A, you reduce the ability to bind to the chromatin, and there's two main phenotypic consequences. You get reduced S-phase replication, so you get increased reliance on the ATR cell cycle checkpoint, and therefore if you inhibit ATR with an ATR inhibitor, you potentially get cell death. And then secondly, they get reduced topo2 binding, reduced chromatin binding, and this is a bit analogous to having a mismatch repair deficiency, so you get this decatenation effect and a kind of higher mutational burden, potentially sensitizing to immunotherapies. We know from animal studies, and in fact studies in patients, that clear cell cancers are far more immunogenic than the high-grade serous. We see many more, a much higher tumour mutational burden, many more tumour-infiltrating lymphocytes in the cells, and high levels of PD expression. And some early data from the immunotherapy trials in platinum-resistant ovarian cancer, which were overall a bust, suggested that there were high rates of response in the clear cell patients, so about 20% versus 8% in the whole patient population. So looking at ways to target ARID1A, the ATARI trial, this is a UK-run study by Susie Banerjee at the Marsden, and here they took patients with clear cell cancer and other rare subtypes with or without an ARID1A mutation, but essentially looking to see if ATR inhibitors were effective in this group, and they either received ATR inhibitor, the calasirtib, on its own or with olaparib. And when you look at the overall response rates of the different cohorts, only 14%. That doesn't sound that impressive, but actually the duration of response was 24 weeks. And remember, the median PFS with chemotherapy is less than 2 months. And the disease control rate for more than 16 weeks was about 41%. So it's not going to make a significant change, but it's interesting to see some signs of activity. And it will be interesting to see the translational output from this study if we can better predict response. There's an ongoing arm in combination with immunotherapy. And there's really been a lot of interest in immunotherapy in clear cell cancers, and some of the studies are listed here. First one I would like to show is the Peacock study. So this was a study that we ran, a UK study, looking at very simply pembrolizumab monotherapy in patients with recurrent clear cell. All clear cell gynecological cancers were included, although the majority were ovary cancer. And the study met its primary endpoint with progression-free with 12 weeks with disease control in 43.8%. The response rate was 25%, but another third of patients had disease control, and the median duration of response was almost a year, 48 weeks. And you can see here from the swimmer's plot that there are a number of patients that had long-term disease control. A more recent study looks at the combination of nivolumab with ipilimumab in patients with clear cell ovary and endometrial cancer. They had the combination for 4 cycles and then nivolumab monotherapy, and really impressive response rates. So more than 54% of patients had a response, including some with a complete response. Similar rates between the clear cell ovary and the clear cell endometrioid. The median duration of response has not yet been reached, and more than half of patients were free from progression at 6 months. So really game-changing results. These are studies in small numbers of patients and really require confirmatory phase 3 trials. As yet, no immunotherapy has been licensed in clear cell, but there's definitely some encouraging signs of activity. It's worth noting this combination is far more toxic than the monotherapy, so there are high rates of grade 3 and 4 adverse events and 1 treatment-related death. As I said, there's a lot of trials ongoing looking at immunotherapy in clear cell. I've listed some of them here in combination dual immunotherapy with anti-angiogenesis or targeted therapy, and hopefully the outputs of these will lead to approval in this hard-to-treat patient group. And then finally, the mucinous ovarian cancers. I think we all, when we have an advanced mucinous cancer in the MDT, really our heart sinks because we know how hard these patients are to treat. It's uncommon, only about 3% of the ovarian malignancy. We know it's hard to distinguish from GI cancers. And in the advanced disease, they have the worst survival of all epithelial subtypes. We see quite frequent KRAS mutations, but as I'll show you, they don't seem to benefit from the MEK inhibitors like the low-grade cancers do. And then perhaps there's some signal of hope with the HER2 amplification. The problem with these cancers is they're so rare, it's actually very hard to perform trials in this patient subgroup. So the MEOC study from many years ago that Professor Gore ran tried to randomize patients between gynae chemotherapy, carboplatin and paclitaxel versus GI-type chemotherapy, and they had to close it because of poor accrual. And then the second problem that they had was when they looked at the pathology of the patients that had been enrolled, actually less than half of them actually had mucinous endometrial cancer. So this highlights the challenge that we have in rare ovarian cancers. They're small patient numbers, they're diagnostically challenging, a bit like the small cell cancer we heard about. They often have very aggressive disease and they can't wait around a long time for trials, and there's really not very much interest from the pharmaceutical companies to fund drug trials in these small patient groups. But there are solutions. We can think about platform studies, basket studies, and really utilising all our collaborative networks. So we've got the GTG, the BGCS, ENGOT, and the wider ovarian cancer networks. A really nice example of this is a platform study run by the ENGOT group. So the Bouquet trial, this took all rare ovarian cancers. So they all had molecular testing, and then patients were stratified to a treatment arm based on what biomarker they expressed. And you can see some of them here. Unfortunately, the sponsor, the pharmaceutical company, pulled the trial, probably because of lack of commercial interest, but it recruited very well, and we got some interesting data that might form the basis of further studies. I include the ones that are most relevant to mucinous cancers. So here, this was patients with a mutation in the PI3 kinase pathway. So frequently mutated in clear cell, as you can see, each line represents a different patient. The purple ones are the clear cells, and the one at the top is the mucinous cancer. And they received the combination of inavolisib, which is a PI3 kinase inhibitor, and palbociclib, a CDK4/6 inhibitor. And actually a very nice response, about 25% response rate, and a couple of the patients had a really long duration of response. So the ones at the top had response for 12 months, and I think that's something we just don't see in mucinous cancers. The second arm I include, just to show the lack of response in mucinous cancers, this was cobimetinib. It's another MEK inhibitor. Unsurprisingly, we saw benefit in the low-grade ovarian cancer patients. They included 5 patients with mucinous cancers with KRAS mutations, and there was no benefits. So just because they've got the same mutation doesn't mean they'll respond to the same drug. A different example of a trial is a basket trial. So here we have patients all with the same mutation but with different cancer types, and this was a global study looking at the HER2 antibody drug conjugate for all non-HER2 positive, for all non-breast cancers that had a HER2 amplification, and here patients were treated with the ADC. You can see that the rates of HER2 overexpression in ovarian cancer are quite varied, but the mucinous cancers certainly have the highest rates of HER2 overexpression. And when we look at the results, the ones circled there, the ovarian cancer cohort, actually a very nice response, 45% response. When you look at the figure on the top right, the waterfall plots, nearly all of the patients had some degree of tumour shrinkage and a good duration of response. We don't yet know the histological subtypes from this trial, but it's likely to be presented at ESMO. But as you saw from the previous slide, mucinous cancers do have relatively high rates of HER2 expression, so it may lead to some hope in this tumour group. Based on these results, again, only in the USA, they've approved this treatment for any HER2 positive cancer. So in conclusion, we know that these advanced non-high-grade serous epithelial ovarian cancers often have poor prognosis. They're nearly always excluded from our standard platinum-resistant trials. We no longer consider it as a single disease entity, and we're really changing our treatment strategy based on our increased understanding of the molecular pathogenesis. There is some hope by applying precision. We have seen some treatment approvals, albeit to date only in the USA. So we've got this combination for KRAS mutant low-grade cancer, the TDX1 for HER2-positive gynae cancers. But I think in summary, the keys to success is we have to be smart, think about good hypotheses, use the science to drive the clinical trial design, and really collaborate with all our networks, because these are hard studies to recruit to due to low patient numbers. So anyway, thank you very much for your time, and I'd be happy to take questions in this session.
Thank you very much indeed. And finally, can I invite Professor Karin Kreutzberg to come and talk to us? She's a Professor of Radiation Oncology at Leiden University Medical Center. Thank you.
Thank you so much. Ladies and gentlemen, it's a big honor and a privilege to be here and discuss tumor profiling and tailoring of endometrial cancer treatment. I have no conflicts related to this presentation, and I think by now you all know the 4 molecular subgroups of endometrial cancer, the POL-E hypermutated cancers with an excellent prognosis, the mismatch repair deficient cancers, hypermutated, with an intermediate prognosis, the P53 or copy number high cancers, serous-like, driven by P53, which have an inferior prognosis compared to the others, and the copy number low or no specific molecular profile cancers. Most of the low-grade endometrioid cancers are within that group. These can be detected in everyday pathological tissues using surrogate markers, using mismatch repair protein and P53 immunohistochemistry and DNA sequencing. And with these new findings published in 2013, lots of other groups have confirmed the prognostic and predictive properties of these molecular markers. And it has been adopted by the WHO, and important is that you first have to decide on POE mutant cancer or mismatch repair deficient cancer because of all of their mutations, so don't overcall P53 mutation because they can also be a secondary one in the scope of POE or MMRD mutant cancers. So for mismatch repair deficient cancer, the immunohistochemistry is also the advantage of an easy diagnosis for patients who should be suspected for Lynch syndrome, because about 30% of all cohorts of endometrial cancer are mismatch repair deficient, but most are based on MLH1 promoter hypermethylation. And only if that's not found, then the patient needs to be tested by the clinical geneticist for germline mutations, and that's ultimately found in about 10% of all mismatch repair deficient cancers, or 3% of your average population. But this is a much more efficient way than do age-based testing. The other or unexplained mismatch repair deficient cancers are largely based on double somatic hits. So this is another important way to detect Lynch syndrome. Another non-molecular but important clinical pathological marker of spread and higher risk of death is substantial LVSI. The quantification of LVSI into no, mild or focal or substantial has made a real difference in the prognostic power of this marker, and is both predictive of lymphatic but also distant spread by hematogenous routes. So even in a population which was confirmed node negative in the Swedish population registry, LVSI was the strongest factor with a 2.5 higher risk of death based on spread via other routes. And in the PORTIC-2 trial, when we retrospectively tested for the molecular groups, we had the same difference in prognosis, even in this high intermediate risk population. And if we combine that with substantial LVSI and L1-CAM overexpression, those who had one of those three risk factors, a small group within the complete population, but they benefited from external beam radiation to ensure pelvic control as compared to vaginal brachytherapy. So while the trial was overall determining the best adjuvant treatment were vaginal brachytherapy, there was a subgroup with a higher risk benefiting from external beam. And that was the basis of the PORTIC-4A trial, the first trial worldwide to base treatment on a molecular integrated profile. Patients were 2-to-1 randomized between treatment based on the profile or standard vaginal brachytherapy. And in the profile, if a patient has substantial LVSI or P53 mutation or L1-CAM overexpression, they were deemed unfavorable, while there were POE mutated cancers or cancers without any of the other factors were favorable, and an intermediate group received the same vaginal brachytherapy. So observation for low risk, targeting the way to reduction of over-treating these patients, but also reduction of under-treating them by using dedicated external beam radiotherapy for those with an unfavorable profile. The results were just presented at ESTRO 2025 with a primary endpoint of vaginal recurrence, and we had very low recurrence rates in both arms, with 45% of those in the molecular profile not having had vaginal brachytherapy. So the risk was slightly elevated at 5 years, as we also expected from the PORTIC-1 and 2 trials, and the equivalence margin was set on 7%, so the results showed that it was non-inferior to standard vaginal brachytherapy with much less treatment. And if we looked at pelvic control, so the risk of local regional vagina or pelvic relapse by molecular profile, you can see here that the profiles adequately determined the risk profiles among the complete trial group, and that the small group of 15% with an unfavorable profile clearly and significantly benefited from external beam radiotherapy. So here is the prospective confirmation. So PORTEC-4 leads to clearly more individualized adjuvant treatment, with about 45% of your patients not needed to have upfront vaginal brachytherapy, a huge reduction in cost and your resource used, and 14% needing EBRT for an unfavorable profile. We have, of course, also looked at complication rates of patient-reported outcomes. The adverse event rates were very, very low and only mild, and details of that will be presented at BGCS in November, along with a cost-effective analysis. So which adjuvant treatment then for high-risk endometrial cancer? And you can see here that it is important to see what kind of cohort you're looking at, because the high intermediate risk cohorts in PORTEC-1 and 2 and also PORTEC-4 have a different distribution of the molecular groups. In PORTEC-3, we had fewer NSNP cancers and clearly more P53 and POLE mutated cancers, and about the same 1/3 of mismatch repair deficient cancers. Also, recent research, and you heard it also already from David, shows that NSNP cancers is not a homogeneous group. They are defined by not having the other molecular characteristics, but it has become really clear that estrogen receptor is the most important factor within the NSNP group. If cancers are estrogen receptor negative, this is associated with unfavorable histologies, with higher grade, with L1-CAM overexpression, and those patients have a clearly different prognosis. This is the red curve, showing a clearly less favorable outcome compared to those with estrogen receptor positive disease, even with or without progesterone receptor positivity or negativity. And in this cohort of over 600 patients, the estrogen receptor negative NSNP cancers had the same inferior outcome compared to the P53 mutant cancers. So when we recently looked at the 10-year results of the PORTEC-3 trial, and you know the trial, many of UK colleagues have collaborated in this trial. It was a trial for high-risk cancers with about 1/3 non-endometrial cancers, 1/3 grade 3 or stage 3 cancers, and 45%. And the trial looked at the benefit of adding chemotherapy during and after radiotherapy to improve outcomes. Overall survival was published in 2009 to be 5% different in favor of the combined arm, and most benefit was found in stage 3 cancers and the cancers with serous histology. And when we did the 10-year analysis with more than 9 years of follow-up in over 80% of the patients, and including the molecular classification, which was known in 66% of the cancers, we saw that the primary survival outcomes were confirmed. 10-year overall survival benefit was 8% and recurrence-free survival 5% with the addition of chemotherapy. And if we look back at the stage 3 cancers, more than 10% survival benefit with the addition of chemotherapy. Still, of course, when we look at the molecular groups, we really want to know who is benefiting. If you look where the recurrences were in the PORTEC-3 trial, they were rarely in the vaginal and pelvic area, reflecting the use of external beam radiotherapy in both arms of the trial, and most were abdominal distant, with some additional metastasis detected between 5 and 10 years of follow-up. Survival after recurrence was median of 1.4 years, and those who were younger had a low-grade endometrial histology or ER-positive NSNP cancers with low-volume metastasis had the best outcome, with some living for many, many years after recurrence. And then we looked at the molecular subgroups, and again you see the same pattern. No events in the POLE cancers, except for one. So despite if you give radiotherapy or with chemotherapy, no difference, so they don't benefit from your adjuvant treatment, and we should look at de-escalation. Well, the The P53 abnormal cancers were again those with an unfavorable prognosis, the red curves. And when we looked specifically at the 4 molecular groups and compared the trial arms, you can see here that we didn't find any sign of benefit with chemotherapy for mismatch repair deficient cancers. So maybe they need another approach. P53 cancers really significantly benefited from the addition of chemotherapy, with more than 10% benefits for both overall and recurrence-free survival. And this only for a part postponing recurrence, but there are some cures also. For NSMP cancers, survival was a trend for benefit in overall survival, but there was clear trend for recurrence-free survival, and it seemed that a number of them was only postponement of recurrence. Well, if we looked at ER-positive NSMP cancers, overall survival curves were overlapping with or without chemotherapy, while recurrence-free survival was slightly different, but with conversion of the graph, so it seems that it's mainly postponement of recurrence. While for the ER-negative, and this is only a very small subgroup, so it's only hypothesis-generating data, we had a clear benefit of adding chemotherapy. So 10-year conclusions that indeed with the addition of chemotherapy you improve survival and recurrence-free survival. There are infrequent late recurrences, most were at distant sites, and the largest benefit is found in P53 abnormal cancers of all stages and the NSMP ER-negative cancers. But mismatch repair deficient cancers and POE mutant cancers did not benefit from the addition of chemotherapy. And we all know from the trials which were mostly done in metastatic disease, and the Keynote B21 trial, was the first to have also adjuvant treatment in their trial comparing chemo alone or adjuvant chemo with checkpoint inhibition. It was an all-comer trial, and I hope we'll be seeing then in the next decades more molecular-driven trials. But within this all-comer trial, which was overall negative, the subset with mismatch repair deficient cancers clearly benefit from a hazard rate with 0.3, similar to what was seen in metastatic trials. Most of these patients also had radiotherapy, and if we see that immune checkpoint inhibition is so effective and chemo didn't seem effective in the PORTIC3 trial, the question is chemotherapy needed with checkpoint inhibition? Is radiotherapy needed? Can we use it in a neoadjuvant phase? And luckily, many trials are already ongoing with asking these questions. And the turn to neoadjuvant checkpoint inhibition has also started, similar to rectal cancers. This is a very small window study before surgery. Patients received 2 cycles of neoadjuvant pembrolizumab. It was done in Groningen by Nijman and de Bruin and their team. And they saw what we see often, about 50% overall response to the checkpoint inhibition, but some really profound response with only 2 cycles. And this trial is now continued with more cycles of 6 months before surgery. So likely there is a subgroup who can achieve pathological complete responses similar to rectal cancer. And this is the last topic. There are now deep learning and artificial intelligence tools to predict molecular group, to predict prognosis and response, also in endometrial cancer. And of course, this is faster and cheaper. 1 or ideally 3 representative H&E pathology slides are used as input, and then this system can predict the molecular group. And you see on the left-hand side that the distinction between POE and mismatch repair deficient cancers was most difficult for the machines because of the dense immune infiltrate. So what we're doing now is to do first mismatch repair deficient testing, because we needed it anyway for Lynch screening, and then use the system to distinguish the other 3. And the next step is Hector to predict distant recurrence and also a response to therapy with the input of only the whole slides and the anatomical stage in the uterus. This has been tested on a fully digitized data set on almost 3,000 cancers, having test sets and validation sets. And the 10-year distant recurrence-free probability was clearly different by Hector risk group, Hector low risk, Hector intermediate, and Hector high risk. And if this was also confirmed in the external set, and if we use this to look at the Portex-3 data, then indeed Portex-3 Hector low risk and intermediate risk did not benefit from the addition of chemotherapy, while the Hector high risk clearly benefited, even with more stronger separation of the curves compared to the P53 abnormal cancer curve in Portex-3 trial. So this is a really promising way to detect both prognosis but also predict the best treatment in endometrial cancer. So what is the next step? Obviously, this is treatment based on molecular risk factors. And we've now the investigator-initiated Rainbow international studies where many groups worldwide are participating in a different trial for each molecular group. Chemoradiotherapy as the basis for P53 abnormal cancers, but with or without PARP inhibition. This is led by Alexandre Léry from France. The mismatched patient groups will be compared radiotherapy alone or with checkpoint inhibition because we didn't find benefit of chemo. This is led by Judith Groep from the Netherlands. The NSNP cancers who have now, if they're advanced stage, have the indication for chemoradiotherapy, but we think they might have the same benefit if they're ER positive from hormonal treatment, revisiting the hormonal treatment as an adjuvant therapy, but then in the really cancers who might likely respond, and that is led by Emma Crosby and Melanie Powell here in the UK, and the P50, if the POLE mutant cancers who need de-escalation of treatment, and this is led by the Canadian group of Jessica McAlpine and Kathy Han. Most of these are already recruiting, and only the Orange trial is expected to open up very soon. So this is one of the ways to take this forward. So individualized treatment based on molecular risk factors is here to stay and is our future. They have both a prognostic and predictive role, and they can help us to further individualize and personalize treatment. Please participating in trials. It helps yourself and the field and the patients with innovative treatment. There is an emerging role of artificial intelligence. And we are now on the way to de-escalation for low-risk cancers, to more effective treatment for the higher-risk cancers, and a clear role of immune checkpoint inhibition for mismatch repair deficient cancers. So together we will be having different treatments in the future and more tailored to our patients. And as the previous speaker said, the fun and the real work of trials and of improvement of therapy is in collaboration. And I'm really thankful to all of collaborating, the patients, the professionals, our friends, colleagues over the whole world. Thank you so much.
Thank you very much indeed, and thank you very much to all of our speakers. We've got about 5 minutes now for any questions from the floor to our panel, please.
So I'm going to start, if that's okay. So, Bea, with the pentacultures at the moment, sort of any plans for extending that, including more cell lines?
Yes, so Josh, which is not only a CAR T-cell expert in our lab, but also a bioengineer which developed the microfluidic chip, is planning to take the pentaculture and try to add it into the vascularized system to deliver CAR T-cells. So that should bring us to 7, which is heptaculture. So yeah, that's the plan for now.
Thank you. I just wanted to ask Michelle about your trial and whether you're looking at quality of life for women on the adaptive arm. The reason why I'm asking is because you're obviously aiming for a certain tumor bulk to, to have the chemo-sensitive cells as well as the chemo-resistant. And then it means that they are likely to be on chemotherapy for longer. They also are likely to have a higher tumor burden throughout. So is there a period where those women are actually well and in remission?
Yes, so the short answer is yes, we are evaluating quality of life as a secondary endpoint. We're kind of quite interested in it, actually, because people have different views on it. So some of our patients have been put off by the extended period of therapy, whereas others are very attracted to having potentially lower doses for longer. So yeah, we are monitoring quality of life, but also monitoring fear of progression, because we just wondered if that could be a consideration for people if they're potentially having a lower dose. And the other thing, we're also looking at our screening data really closely and with quite a lot of granularity to understand if the treatment duration impacts people thinking. So yes, the short answer is yes, we are.
Thank you.
Hi. Thank you for all the talks. Absolutely fascinating. I just had a question with the pentaculture in particular. In terms of the cells that you're using in the pentaculture, where do you get the cells from? Is it from tissue? Is it from cell lines or from healthy donors? And if it is there any priming that happens before you put them in?
So we have primary cells, which are the adipocytes, the fibroblasts, and the mesothelial cells, which we isolated from tissue from patients. So these are women undergoing high-grade serous ovarian cancer surgery, which have a part of their omentum which is uninvolved of the disease. So we take that part and we isolate the cells which are normal-ish, let's say. So the adipocytes are fully differentiated, so we don't culture them very easily, so we just encapsulate them in a gel, so they're just floating as the gel that I showed you before. Yeah. The malignant cells, they are immortalized malignant cells. They were primary originally, two of which we immortalize ourselves. One is commercially available. And the monocytes we isolated from blood donors, so they are primary themselves. But there is no priming before putting them in, and literally they do everything. Whatever they form in morphology, the differentiation from monocytes to macrophages happens only because of what the other cells are secreting, so the crosstalk between the different cells.
That's fascinating. Thank you so much.
Thank you.
I had a follow-up question to that. Have you looked whether the secretome of the cancer cells are what are reprogramming your pentaculture, or does it really require a cell-to-cell communication?
So we look at the secretome of both the 2D cell line, all the cell lines in 2D, and the pentacultures. There is differences in the abundance, and there is differences in the types of cytokines being released. I've tried to use the conditioned media from the cancer cells and just put it on a penta minus the cancer cells, so a tetraculture, to see if the macrophage will differentiate in the same extent. They start at least, but they are not as diverse as they are when you add the cancer cells on the culture together. So yes, there is definitely malignant cells macrophage interaction that drives the macrophage phenotype, but we cannot exclude the importance of the other cells as well. Yeah.
Thank you.
Thank you for the excellent presentations. I just have a question about the adaptive trial. Correct me if I'm wrong. Is there, in the eligibility criteria, anything in relation to the surgical outcomes?
Sorry, could you repeat that in relation to the...
To the surgical outcomes, the outcomes from cytoreduction?
No, I mean, these patients, no, there isn't.
Because I can't help but thinking, I think, you know, there is a proposed mantra from the mice cell experiments that the resistant cells kind of outgrowing the sensitive cells, if I'm correct, which probably, you know, gives food for thought for the surgeons in the audience, that they could be less disheartened about achieving suboptimal outcomes, and perhaps consider removing the bulk of the tumor during cytoreduction that might create some eligible patients for trials like this.
I don't think we have evidence to support that at the current time. I mean, the point of this trial is the patients all already have relapse disease. So, you know, what happened years prior in surgery probably isn't relevant. Look, I'm not a surgeon, so I don't want to kind of comment on the evidence to support complete debulking, but I don't think we're at a stage where we could advocate for that at the current time.
Okay, thank you.
Okay, thank you very much indeed to our speakers. Please do approach them at lunch if you have any further questions, and do go and meet our sponsors who very kindly supported our meeting today. Thank you very much.
Thank you.